Good morning to everyone. I'll be presenting today on cell therapies and liver organogenesis technologies, promising strategies for end-stage liver diseases. I've tried to cover this in two aspects, which is introduction, then something on MSCs, macrophage therapies, a short course on liver organoids, and some newer concepts that we can imbibe in our practice. So why does end-stage liver disease actually require? The reason is end-stage liver disease is characterized by irreversible hepatic dysfunction. Liver transplant still remains the only definitive option, and cell therapies could actually represent a promising and emerging therapy for this. So we all know that liver is a regenerating organ, and if regenerated possibly in the best possible way, you can even restore 100% of your liver. So most of the cell types that you see in the liver are of these 7 types, which is the hepatocyte, the biliary epithelial cells, the hepatic stellate cells, the liver sinusoidal endothelial cells, the Kupffer cells, and the macrophages. And on your left-hand side, you can see is what happens if there's a chronic injury. So there can be retraction of the hepatocytes, there can be expansion of the biliary epithelial cells, there can be activation of the hepatic stellate cells, activation of the endothelial cells, depletion of macrophages, and recruitment of PAMs and DAMs that we would see subsequently in the other slide. So this is what typically happens in liver injury. So why does regeneration in chronic liver injury, what's the actual issue? And the issue is hepatic senescence. And the hepatic senescence, if you can see, inhibits the hepatic proliferation. So the reason why you need a regeneration is because the senescence is not terminal and it reverses with change in environment. So it thereby becomes very important that we have cell therapies that can actually change that sort of an environment. We also know from previous studies that there is macrophage dysfunction, and there is a lesser number of macrophages which are present in the liver as well as its phagocytosis. We'll see briefly in the subsequent slides how that helps. And this is also one of the targets that can be used for these cell therapies at this point in time. So my first slide was that why do we need ESLD, and the reason is because liver transplants, though it's the only curative option, the requirement is so high, but most of the time we barely get the amount of livers that we need. So what we need is something that can help in reconstituting the hepatic reserve, something that can promote liver regeneration, and of course bioartificial liver. So these are some of the cell therapies that have been published or discussed, namely hepatocyte transplant, stem cells, multicellular therapies, some certain immune therapies which are there, and I'll be briefly touching upon all of them in the subsequent slides. So the first question to ask is the liver the right candidate for such therapies? Previous slides have shown that yes, it has regenerative potential and it can subsequently be used. Now this is a very busy slide, and on the left you can see here that this slide here, I really couldn't understand of how exactly we come about this liver cell injury. So what I've done in the next 2 slides is to have simpler version of how these liver cell injuries happens, and I'll take you to the left part where you can see there's a patient who comes in with an injury and how does a doctor treat. So the first is to identify the injury. So how do you identify the injury, especially for mesenchymal stem cells, is using their paracrine and immune modulation functions. So what it does is it inhibits macrophages, NK cells, dendritic cells, TNF alpha, IL-6. It also stimulates hepatocyte growth factor, vascular endothelial growth factor, insulin-like growth factor, and IL-10. All of this would then lead to liver cell proliferation, inhibit the apoptosis, and reduce the inflammation liver. So this is identification of the injury which happens. You also have migration and differentiation, something called the hepatocyte-like cells. Now coming to the anti-fibrotic action of these stem cells, they stimulate the matrix metalloproteinases. They also have the TIMs, which are the actual inhibitors. All of that would lead to a decrease in ECM deposition and also the hepatic stellate cell activation, which I had shown in the previous slides. Also, the VEGF has an anti-apoptotic action as well as decrease in proliferation. It causes an increase in the BCL2, which is anti-apoptotic, and causes a decrease in the BAX, which is a pro-apoptotic gene. When it comes to healing, as I had mentioned here, which was the hepatocyte-like cells, you have the hepatocyte-like cells, which also activate the exosomes. The exosomes in turn activate the MIR-181 as well as the MIR-122. All of that would increase the autophagy, again reduce the apoptosis and promote regeneration. And then there is angiogenesis, which can be done with the help of the endogenous stem cells. So these are some of the basic actions, and this is where some of the targets that we will place. Another important component of liver cell regeneration is Kupffer cells. So if you look at the Kupffer cells, if you go by our previous example, how do they identify the injury? They identify the injury using PAMs, which are basically seen from the bacterial translocation in the gut, the DAMs, which are from the damaged hepatocytes. All of that leads to the activation of the TNF alpha, thereby IL-6, IL-12. All of that helps in reaching to the site of inflammation. It also helps in decreasing the fibrosis by activating IL-4, IL-10, 13, TGF-beta-1. The IL-10, on the other hand, also activates the Th1, MMP9, MMP12, which helps, as I had shown earlier, also in the ECM degradation, thereby helping in fibrosis. You also have a component of the CD31 and the CD34. Both of them are extremely critical. As you can see, a CD31 helps in angiogenesis, regulation of the immune cell migration, as well as the capillary formation, whereas CD34, with the help of the endothelial proliferation cells, the hepatic progenitor cells, have antifibrotic action. If you see here on this diagram very clearly, you have the zone 1, you have zone 2, and you have zone 3. So whenever there is an injury, so you can see here, these are the pro-inflammatory macrophages, the M1, and you have the anti-inflammatory macrophages. So whenever there's an injury, as you can see here from the zone by itself, you have the CD68 macros which are activated, thereby causing inflammatory as well as anti-inflammatory actions. And the PPARs over here also help in the anti-inflammatory action. So these are some of the basic concepts that we see along as we discuss this. So bone marrow cell therapy, which has shown a lot of promise, as I had already shown earlier, well, it helps in activating the osteoclast, it helps in clearing the damage, provides the paracrine function, which we've already seen, also rescues some of the non-parenchymal cell mass, as well as remodeling of the extracellular matrices, and that leads to regeneration. So this is a proof of concept which was performed here at ILBS, and what we see here, that if you have a novel approach to these bone marrow cell therapies, you can actually restore the long-term reserve which is there. You can accelerate the regression of fibrosis, you can potentiate regeneration, as well as prevent development of decompensation. So there has been data which has even come from our institute which has shown that all of these functions can adequately be done using the bone marrow therapy. The other thing is the bone marrow rejuvenation. As I had already shown, it can help in reduce the onset of ascites, it can decrease fibrosis, it can decrease hepatocyte death, it can increase regeneration in all of these subgroup. So some of the trials which have been performed, and these have happened over the years, some of them are very old trials, most of them were initially uncontrolled trials, and all of them looked at a single dose installation via the hepatic artery, and the results were that they did show a decrease in bilirubin, INR, albumin, there was decreased onset of ascites. But as we went in towards more of randomized controlled trials, what we found out that there were no significant differences between the groups who were receiving bone marrow therapy versus the ones who were not receiving bone marrow therapy. Some of the other trials which were done, very small numbers, about 5 patients, 9 patients, all have shown that there is some improvement in the liver parameters, in the CTP score, but again, they do not really cause a decrease in MELD score or even the liver cell dysfunction. The other component is GCSF, and GCSF, which we will see subsequently, has a lot of other functions. As you can see, going back to our previous concept, the GCSF also helps in the production of neutrophil mobilization, thereby decreasing infection. We will see an article which showed that it causes a decrease in infection. It decreases fibrosis by again activating the hepatocyte proliferation, increasing CD161, and at the same time also causes the bone marrow stimulation by increasing the osteoblast and increasing CD34 HSC which is there. So GCSF has shown promise, and you will see subsequently that there are many studies which have been done to look at GCSF. So the trials of GCSF, these are many of them, but I think one of the first few were in 2012, which was a double-blind randomized trial. These were all ACLF patients in 2013, and they had shown that it improved the MELD score as well as the survival and lesser amount of sepsis in this group of patients. We also had a trial from ILBS, which was in 2015 published in Gastro, which had shown that multiple doses, subcutaneous doses over 4 weeks of GCSF and darbepoetin improved the CTP, MELD score and survival at 12 months as well as decreasing sepsis. So this was a study which was done here, which showed that if you have early cirrhosis, you have a preserved bone marrow, it helps in the regenerative response to growth factors. And if you see here on your left, you have CD31, CD34, and the osteoclast. So when you gave therapy to all these individuals, you had an increase in CD34 and a decrease in CD31. And as I had shown earlier, CD34 was an anti-apoptotic factor which was used in this group. So thereby it helped in improving the macrophage reserve, reduce the fibrosis, as well as increased regeneration. So GCSF, as we go by, has been studied in other forms of ACLF. Studies coming from India which have looked at the continuation of GCSF, mostly in alcoholic hepatitis. And we had a study from Dr. Shastri which had looked at the addition of GCSF to patients who were steroid non-responder and had shown a survival of nearly 71% at 60 days and a 90-day survival of 64% in this group of patients. So GCSF has been actively used, though the study population has been ACLF or alcoholic hepatitis. And going further, it has also been shown that it reduces the incidence of hepatorenal syndrome, it reduces the incidence of HE, as well as bacterial infection which can be present. So there has been multiple effects. So what happens is that if in alcoholic hepatitis, you can use steroids and you can add on a GCSF right at the beginning. And this was again done here by Dr. Ajay, who looked at the GCSF improvement in predicting prednisolone responsiveness and 90-day survival. So they had 3 groups, one group which continued with prednisolone, the other had an addition of GCSF, and the third was GCSF itself. And the study results were very promising. What they showed was that the onset of infections, acute kidney injury, hepatic encephalopathy, rehospitalization was much lower in the patients who receive a combination of steroids plus GCSF versus just steroids alone. So GCSF as well as certain of these bone marrow therapies have shown promise and have shown some benefit in clinical trials. But there is a slight challenge when it comes to bone marrow therapies. And as we have seen on all the papers, most of these papers were 90 days, they were probably 6 months. So the biggest problem that happens with bone marrow is the preservation of the bone marrow pool. And this was again in the same study which I had quoted earlier. You see, as the time lapses, the percentage of the bone marrow reserve actually shrinks. So the persistence, so the fact is that how do you keep the bone marrow reserve up to an optimal level to achieve an optimal response is, I think, still lacking in these subset of patients. So mesenchymal stem therapy, as I've already mentioned, these are the master regulators. This was right in the beginning. It helps in chronic liver injury. I've not touched on acute liver injury, though there is a lot of data on acute liver ALF as well. They help in liver regeneration and all of that. So the first trial that we saw was in decompensated cirrhosis, and this was the autologous infusion of bone marrow stem cells and in patients with decompensated cirrhosis. And very small subgroup, but what they did show, out of 4 patients, 3 patients had improved their MELD score at 6 months after transplant, and 2 of them continued to improve up to 12 months. So these are some of the initial studies. They used an iliac crest puncture to derive these cells, and after that they injected about 32 million autologous MSCs in this group of patients. This was one of the first few data in decompensated liver disease. Some of the other data which has come about in decompensated liver disease, as you can see here, causes a decrease in MELD, causes a decrease in bilirubin. But when you did a randomized control trial, and this was again in 2013, long time back, there wasn't any difference between the group. So even though there are change in liver parameters, there are change in liver function, the overall acceptance at this point in time is still not there. In the same study which was done, this was a pooled analysis of stem cells for overall liver disease. You can see that there is a change in liver function. So there is an improvement in MELD albumin, ALT, bilirubin, PT, but there is no improvement in INR as well as the CHE level. So thereby says that increased coagulopathy or even advanced stage of liver disease, maybe these cell therapies may have a slightly limited role. So maybe we need to act or instill them a lot earlier. So there is a beneficial effect, but it is not prolonged and it is only transient, as I had come to my earlier point. So the duration of these therapies have to still be determined, whether this is a therapy which will go on for say a certain time point or whether you keep on changing these therapies. So it's very important for us to still now decide what is the optimal duration to give these therapies. So this was another paper in decompensated cirrhosis. This was a long-term analysis of a randomized controlled trial. Well, they did show that this randomized controlled trial, if you can look here very clearly, most of the bilirubin levels were in the significant range, nearly 7.6. And they did show that it increases the survival in decompensated cirrhosis, but the evidence is only for 13 months after the MSC infusion. So the survival benefit is about a year, and that's about it. And after that, the survival starts diminishing because of the transient effect that it has. Macrophage therapy, I had briefly told you the importance of Kupffer cells in liver repair and liver regeneration. And this is again a very widely studied area. There's a very recent study which has been published, and these are some of the factors which look at it. So most importantly, what it does, especially in liver failure, is phagocytosis of the pathogens, as well as it causes a liver repair as well as liver regeneration. So if you look at the liver macrophage pool in liver failure, though I've just put one slide on acute liver failure. As you keep seeing the liver macrophage pool in these patients of acute liver failure as compared to patients of decompensated cirrhosis, you can see the CD68 is actually much less when it comes to patients with acute liver failure. So there is a progressive loss of hepatic macrophage with increased liver fibrosis. So there is a loss of macrophages even in patients with decompensated cirrhosis as compared to other conditions of liver disease, including acute liver failure. So this was initially an animal trial which looked at the macrophage therapy, and even this trial had shown that there was some result in improving the macrophage activation, but not so much in improving the macrophage reserve. This was a recent trial which has been published in Nature, which was actually a phase 2 RCT, and this was close to 51 patients. And these 51 patients, what they did was one arm received standard medical care, the other arm received macrophage therapy. And what they looked at was the delta MELD change, which was at day 0 to day 90. And what they found was that there was no significant difference between any change of MELD score between either day 0 or day 90. However, they did find that the interleukin levels were significantly higher in the macrophage treated group at day 90. So even though it was a very short term trial only for day 90, they did show that there is a slight increase in the interleukin levels, but it did not have much effect on either the MELD score or even the liver disease progression. There is still a lot which is to be done in this group of patients. One concept that I like to introduce is the presence of the pluripotent stem cells in liver disease. And the reason why these pluripotent stem cells are important is because these form now the regenerative potential. And if you see here, what exactly happens in pluripotent stem cells is if you take a stem cell, so if you have a somatic stem cell, what you do is you use something called as a Yamaka factors. So you put these factors into the somatic cells. You can do it either by a gene transfer or via gene transfer. You can remove the genetic component of the somatic cells and in fact use the pluripotent stem cells to derive whichever organ that you need. So whether it's skin, whether it's a brain tissue or a liver tissue. So what you can see here very clearly is that there is a whole process of an endodermal induction, hepatic specification and hepatic maturation. This is also called the epidermal mesenchymal transformation, called as the EPT. And all of these then make an iPSC human-derived human hepatocytes. Now, why this is important is because coming to our next, which is an hepatocyte transplant. Now, when you do a hepatocyte transplant, the concept being is that you do not have a viable liver. So at this point in time, it's obviously less invasive than a normal liver transplant. The hepatocytes can actually live, and if they can be kept, the patient can reverse to even a pre-transplant stage or even be delisted. So that's what we actually need. Which is an exact source of a healthy hepatocyte are these allogenic healthy donor livers. Most of them are treated with apoptotic inhibitors. There are some alternate sources like the hepatic progenitor cells and the pluripotent stem cells, which I had just shown. So all these can act as source of healthy hepatocytes. How do you instill them? Well, initially it was the portal vein. You could use an ultrasound guided puncture, but yes, it had issues of bleeding, liver failure, hemostasis. The other is using a hepatic artery. You use it endovascularly, and nowadays it's one of the commonest routes to instill the hepatocytes. Now, hepatocyte transplant in decompensated cirrhosis, there's very little data. For acute liver failure, yes, there have been certain case numbers which have been used in hepatocyte transplant. Most of them have not shown a beneficial effect. It has only been shown possibly as a bridge to transplant at this point in time. So the recovery was about 22% and death in nearly 78% of these patients who had an acute liver failure in this group. So what are the challenges of a hepatocyte transplant? The first and most important is the source of a hepatocyte. Where do you get the adequate source of a hepatocyte? How do you instill? How do you engraft? What is the route of administration? I had shown the portal vein, hepatic artery. These are all endovascular procedures, very difficult to perform. And how will they proliferize and colonize into a transplanted hepatocytes? So this is very important, and maybe this is why there can be another concept which will come later, which is artificial intelligence, and how to use AI to sort of predict all of these responses in this group of patients. Coming lastly to the other part, which was the liver organogenesis, I'll briefly run through it. Liver organogenesis, as we know, is like an in vitro hepatocyte sheets. And how do you have these sheets? You have these human hepatocyte sheets, which are then you transplant them onto the incision sites. And this is how you form the hepatocyte sheets. You have a liver chip. A liver chip is the reason why you have these liver chip or liver organoids is because you have the parenchymal cells, you have the non-parenchymal cells, all of them. You also have what you call a microfluid, which can act as a circulation for the liver. So all of these are called the micro-patented liver models, also known as the 3D liver chip in this group of patients. So this is the 3D bioprinting. I will not go into the details of how this is exactly done, but these are all which can be used to stimulate into a three-dimensional view of how a liver would look in this group of patients. So this is transplantation of a recellularized liver graft. Again, you can use this. You can use many of these liver cell graft. These are all recellularized liver, as you can see here, from a recellularized liver to a normal liver, and there's minimal damage to hepatocytes. But I think coming to the next part, which is how do you use an artificial intelligence in cell therapies? And there has been some work, very recent work. As I had shown you earlier, there are a lot of challenges in predicting response. There are a lot of challenges in whether it will proliferate or not proliferate. So can you use an artificial intelligence model also to predict cell therapies? So if you can look here as a basic concept diagram, you have these adult cell, you have blastocytes, you have stem cells here, you have a machine learning model which can be used to either predict what happens to these stem cells, whether there'll be an adequate number, whether there'll be an adequate installation. So this is an article published just 2 days back, which looked at how AI was helping in the iPSC technology, which I had just shown, the pluripotent stem cells. Now this is in a neurodegenerative patient. So what they do is they take the patient's somatic cells, they derive the iPSCs, they delete the mutation carrying neurons, they correct the neurons, and after that they use an age match donor and they create the healthy neurons. Now imagine if all of this can be done using the patient's neurons and the controls. You use the gene expression, also known as gene regulatory expression, and at that point in time identify the disease phenotype. You can identify whether it can help in drug discovery, it can help in drug reactions. Another paper will come in where they actually use this to predict drug reactions to certain other medications, and also to improve the safety and efficacy in vivo in this group. So you can actually use AI in this form. So when you use an AI model, these are some of the other models that can be used to cause a cell structuring with a gene regulatory network using all this, all the paradigm. So this is a very interesting paper which was just published, and they looked at an AI model and they wanted to predict DILI using a liver organoid. And how did they do that? They used a bright field image. Now, a bright field image is a very simple image. You have a slide, and there's a light source which passes through it. The one which passes through it is obviously darker, and where there is no substance, it becomes lighter in shade. So what they did was they used this bright field image on a liver organoid. They exposed the drug on the liver organoid, and from there they made a model which was the BEAT V2 model, which was already pre-trained on 700,000 cell images. So once they did that, they could actually predict 82% prediction of hepatotoxicity using this liver organoid and bright field model. So they used the liver organoid cell culture. They made the DILI toxicity test. On your left, you can see, for example, you have chlorphenamine. There was no changes of DILI which could be predicted based on the bright field model. But if you had, say, a Giftinib, which had the maximum, you can see the dark shade of colors which you can see here. So this is what a bright field image does. So the more the exposure, the more the darker it becomes. So the liver organoids can be used to even predict drug-induced liver injury for patients with liver disease. Another one was a cell-based image machine learning strategy to help in the differentiation of these cells. So they were able to again characterize these cells with inversely. They could even use the differentiation process. They could optimization of the differentiation protocol. These were all cardiac myocytes at this point in time, but even hepatocytes can be used for these differentiation, which can be done. A very earlier work was actually using automated MSCs in machine learning, and what they actually could do was they could actually easily predict over here using these markers, which are all your visual cue markers for classifying MSCs according to their phenotype. So you probably don't need a liver organoid model. You can actually use AI and imaging based analysis to even start predicting the phenotypes of MSCs which are involved. Lastly, coming to the challenges of therapy, one was optimizing route of delivery. One interesting thing I found out whether endoscopy can be used for over conventional methods. And in fact, there has been a very recent this was a long time back, where they used mesenchymal stem cells for ulcerative colitis. They actually used a cauterized needle. They injected the MSCs into the bowel of these patients, and they were transplanted into the model. As you can see here, this was the electrocauterization which they used, and you can see the changes post the delivery of the MSCs into this group of patients. You can use an EUS, as I said, that portal vein is a common puncture in this group of patients. And in fact, they've done an hepatocyte transplant, this is still an animal model, into the lymph nodes using an EUS. So in end-stage liver disease patients, you can actually infuse hepatocytes into the lymph nodes by using an endoscopy. So that can be one route where there's a direct access of these subgroup of these patients. So I conclude by saying that cell therapies and organogenesis represent a promising approach. Stem cells, hepatocytes, organoids can all prolong survival. We still need well-designed studies and maybe more of artificial intelligence and other forms to actually predict what the outcomes will be using these therapies. Thank you.